Okay, so I was asked to talk about peri-implantitis, actually severe peri-implantitis. So we will limit our discussion to those cases, those situations where it's hard to tell, should we keep the implant or should we remove it? Because sometimes the decision is easy. I mean, in case like this, we know that there's nothing else we can do, but we have to remove the implant. And also, these are cases where probably from the beginning, the dentist knew that something went wrong. But as Ispan mentioned a few minutes ago, sometimes things work for a few years. Then bone resorbs, then you have inflammation. And if you don't have enough bone, the inflammation will cause a disaster. So these are cases which are maybe difficult to treat, but where the diagnosis and the decision is easy. I want to spend instead some time speaking about cases like this. Cases where you see we treated a periodontal compromised patient in the year 2000. We placed implants in 2001, and patient was under a maintenance program for many years. And apparently everything went well and still went well and still went well year after year. He came regularly, nice person, nice patient, plaque control always good. But then sometimes, 17 years afterwards, things got worse. And these are really the nightmares. These are nightmares because, as you can see, things went well for 17 years. And then in 17 months, a disaster happened. Why is that? Well, because he is a periodontally compromised patient. And we know that when we have a periodontally compromised patient, we can never really get rid of those bacteria. So you have to keep an eye on these patients. And now there is a question, what shall we do? And ideally, we would like to go back, just like we do around teeth. Our ideal approach is to regenerate the lost bone in order to somehow go back to the initial time. So a long time ago, about 20 years ago, 15 years ago, I started to treat cases like this with a regenerative approach. And this is one of the first cases I treated in 2008. I had placed these implants in 2000, and then I sent the patient to the colleague for the prosthesis. And 8 years afterwards, he called and he told me that there was a problem. And maybe indeed, this is one of those cases where at that time we did not pay much of attention to the sufficient width of the bone on the buccal level, as Isvan mentioned before. Nevertheless, I tried the protocol using Bios collagen covered by a thick connective tissue graft. And this is the suture, and this is the early healing, 4 years post-op. And this is the picture 8 years after treatment, which is 16 years after placement of the implant. And the results were good. So the preliminary results were good. So I decided to run a study treating implants which had either an SLA or a TPS surface with the same protocol. And this is the protocol I used. After side debridement, EDTA for 2 minutes, saline solution, chlorhexidine gel for other 2 minutes, and the reconstruction was done with deproteinized bovine bone mineral with 10% collagen. And let me show you one of these cases. You see a patient who has a periodontal compromised patient who has been treated for periodontitis many years before, still under maintenance care. And if you look at the X-ray, you can barely see a problem, a bone defect. But if you probe, you see a 13-millimeter pocket with pus. And the problem with her was to convince her to accept treatment because she didn't feel anything wrong. And with severe peri-implantitis, sometimes you have the problem that patients don't feel pain, so they don't complain. And when you open up the flap, you see the granulation tissue, the decontamination with the EDTA and chlorhexidine gel. Look how deep is the defect. Think if we wait a bit longer, the implant, of course, could be lost very easily. Bios collagen in the defect, suture, early healing, and post-op. Now, we didn't treat many patients, only 26. It was a small group of patients. But the good thing is that we're all patients treated by me with the same type of implant, with the same type of treatment, either small bridges or a single crown. And the results were positive in most of the cases, even though there was a difference between the SLA and the TPS. For example, we were able to eliminate all the pus in around the SLA implants, and only 60% of the TPS implants were able to completely fill the bone defect in 25% of the SLA, and never in the TPS. Why is this concept important? Because we can obtain these results, but the surface of the implant, it's going to make the difference. So keep this in mind. The benefit of the BIOS is one story, but the surface of the implant is another story. So we cannot apply the same protocol to every surface, imagining that all the implants have the same surface. Now, some people frequently ask me if I use membranes. And I'm going to show you a case where I did use a membrane. You see here an implant placed 6 years before, and after 6 years you see a severe peri-implantitis. Again, this is the periodontal compromised patient. BIOS collagen was covered with a bio guide, suture, pre-op, post-op, and you see a good result. The problem is that the adaptation of a membrane around an implant in a situation like this is very, very difficult. Therefore, it has been reported in the literature that sometimes the use of a membrane does not provide better results. And other authors also report the exposure of the membrane and infection. Why is that? As I mentioned, the membrane is not that it does not work, that it's very difficult to adapt around the color of the implant. Plus, I have to say that the BIOS collagen works very well even without the membrane. And in cases where there is a need for protection, I like to use a connective tissue graft. As in this case, you see peri-implantitis, soft tissue recession, lack of keratinized mucosa. So we need to have a soft tissue seal around the color of the implant. Otherwise, the BIOS collagen cannot make a miracle. But you see the situation in a very difficult case. This implant is a hollow screw inserted in 1994, and you see the follow-up 25 years afterwards. Now, let me show you another example. Again, implants placed in 2007. You see the X-ray of follow-up 3 years afterwards, and everything seemed well. However, when patient came for maintenance, there was a problem, and you see that part of the problem is the lack of keratinized mucosa around the color of the implant. Now, this is not the topic of the discussion, but we have seen a correlation between the lack of keratinized mucosa and the number of complications related to the absence of keratinized mucosa. So indeed, we love keratinized mucosa. But if we have to treat peri-implantitis and we are lacking keratinized mucosa, we have to pay very much attention to the type of flap that we do. So first of all, we try to be minimally invasive, which means try to avoid vertical incision. We clean the surface, and we also try to keep, if possible, the papilla so that we can adapt the flap in a better way. Look how deep is the defect. That's not easy. And you know that if we don't regenerate, if we try a different approach, even if we have a reduction of the inflammation, we're not probably to be successful. So what do? We take a piece of epithelial graft, we trim it, so we remove the epithelium, then we punch it, and diameter is the same diameter of the implant. so that we can adapt the connective tissue graft around the color of the implant, and we can protect the bios collagen. And you see the suture, early healing, 1 year post-op. Then the patient was for some time not available because he had heart surgery. He came back in 2016 and he had this root, which of course had to be removed. He didn't want to remove it because he had recently heart surgery, so he was on Coumadin, but after a while he was able to remove the root. And this is a situation a few years afterwards. And you see that even in a case where the keratinized tissue is missing at baseline, you can see decent results year after year. Another example, a severe peri-implantitis many years after implant placement, again, in a patient who was basically under control and nevertheless presented a peri-implantitis. You see the pocket is a centimeter deep. The protocol is the same, full thickness flap. Now you see that the probing is 10. This implant is 10, which means that the smooth color is 2.8, which means that the implant is into the bone for less than 3 millimeters. If we don't regenerate this, we're not able to maintain this implant for the years to come. So we graft with bios collagen, but then we have to protect this bios collagen, and we have to create a cuff, a seal around the color of the implant. How do we do it? Once again, connective tissue graft, punched with a diameter which is the same diameter as the implant, suture. Look at the beauty of the soft tissue and look at the situation 1 year post-op, 2 years post-op, 3.5 years post-op. Actually, I was supposed to see this patient recently, but because of the virus, we have postponed the visit. When you judge the treatment of peri-implantitis, please pay attention to the details. So ask for high magnification picture of the soft tissue around the color of the implant years after treatment. Now, how many of these implants treated with good results last for years? Hopefully in a few months, you will be able to read this publication. It's under review now on the clinical implant research, and it's a 10-year follow-up of the first 26 patients I told you about a few minutes ago. You see again here a very difficult case. You see that there is not only an infrabony component, but also a vertical component. So apparently it's very, very difficult. Now, it's hard to imagine that the bios collagen would be so good, but look at the case 1 year post-op, 5 years post-op, 10 years post-op. But you may wonder, okay, this is a case. How often do we see these results? And these are the numbers. After 1 year, all implants were in place. 32.1% was defined as success, which meant no PD more than 5, no bleeding on probing, no pus, no bone loss. 69 were patients who had, 69% were the patient who had an implant, which was considered survival. At 7 years, we lost 2 patients to follow up. We had to remove 4 implants, and we had still 35% of success, and partial resolution was 42%. At 10 years, we had lost a few more implants, and we had 35% of success, 19% of partial resolution. So at 10 years, there is still a significant portion of the implants which are in the position. But what's even more interesting is that if we, if we look at the numbers comparing the two surfaces, we see that the TPS is only about 40%, and if we have the SLA, it's almost 70%. So regardless of the protocol you use, the surface of the implant is going to make the difference. So select your implant not only based on the primary stability or on the possibilities of early loading, but also on the possibility of creating good results if they have peri-implantitis. Because remember, success is always the result of patient's compliance, defect and implant characteristics, surgical technique, and postoperative care. It's always the same. no matter what. But if you do things properly, look at this case. Again, shortly before taking the final impression for final restoration, we see a huge defect in around an area with no keratinized tissue once again. And we again apply the same protocol. And in this case, we placed an extra implant just because, you know, I was not sure it could work. And this is a situation, early healing. But again, I don't care about early healing. I want to see long-term results. 4 years post-op, we see that the implant which presented the peri-implantitis, which was treated, had a little bit of a blood probing, a little bit of a recession, maybe a spot of biliary probing. So what do? We graft the area. In this situation, after the soft tissue grafting, here is the picture of at 5 years post-op. Here's the picture at 10 years post-op. Please remember how it was, how large was the defect. And this is the 15 years post-op. And it's hard to tell where the bios is and where the native bone is. People ask me what type of tissue is around the implant. I don't know. What I'm saying is from the radiological point of view and from the clinical point of view, it looks fantastic. Now, one important thing is that you have to have a good, an excellent soft tissue seal around the collar of the implant. So in a case like this, when you have a deeper implantitis and you have a molar with a furcation involved, you cannot apply this protocol because you cannot treat the implant having a soft tissue seal around the collar of the implant. So what you have to do is to make a decision. Either you save the tooth or you save the implant. Do not try to make two miracles at the same time. And if you believe in the possibility of this protocol, if you believe that it works, you prefer to remove the tooth because furcation treatment is always difficult for periodontists. You now have a soft tissue seal around the collar of the implant. You treat with the protocol I told you about, EDTA, chlorhexidine gel, Bios collagen, suture, and look at the probing after a year. And I'm so convinced now it's working well that I propose to the patient to pay for a sinus lift, to pay for another implant, and to pay for a 3-unit bridge on 2 abutments. I love the comments Isman made about 2 implants, more than enough for a 3-unit bridge. Here you see the 3-unit bridge with time, still stable results. And this situation almost 10 years post-op. But again, please remember that you have to create a soft tissue seal around the collar of the implant. Now, how far can we go? Well, I think we are only at the beginning of the story because I think that if you look at this case, most of you would say, okay, we'll remove it. But I wanted to give a chance. So again, the same protocol. Based on the fact there was a thick band of keratinized mucosa around the collar of the implant. And now you see the early result. 1 year post-op, 3 years post-op. The patient has to come, and I hope she can come because I talked to her over the phone. She's happy with that. But I mean, it's amazing. It's really gives the opportunity to dream about the future because we know that in the future we'll see hundreds and hundreds of peri-implantitis. So we better be careful, but also we better study new ways to treat peri-implantitis. So let me go towards the end to give you only a few important points. First of all, perio patients should always be informed that they are more at risk for peri-implantitis. I hate when I see lectures where they have patients affected by periodontitis and they remove many teeth based on the wrong assumption that implants perform better than teeth. That's not true. If you have a periodontal compromised patient, you're going to have problems either around the tooth or around implants. And you see here is a patient 6 years after initial treatment. We have gone through all the steps of periodontal treatment, and you can see that he has lost recently the first left lower molar. And the first right molar is perfect. Now you see the same situation 6 years afterwards, and now we have a severe peri-implantitis around the implant. And now you can see that he has a total of 5 implants. Why 6 implants, I'm sorry. Why that only? Well, we don't know, but let's face it, sometimes we have a deep defect on the mesial side of the tooth and the distal is perfect. So peri-implantitis is site-specific. Peri-implantitis is the same. So we can never be sure. We always have to be careful. But when we have a case like this, well, we can treat. We can treat even if it's a pocket more than a centimeter, even if it's with pus. We have to make a flap, full thickness flap, graft with BIOS collagen after I told you EDTA, chlorhexidine gel, suture, and you see early healing, 3 years post-op. And you know, if you're lucky, if patient is good, we can keep them for many years to come. And now we have restored the original situation, so we can tell the patient to keep it clean. So there are good chances it will last for many years to come. Number 2, during maintenance, pay attention to the soft tissues, because even if you have good plaque control, as in this case, you see 5 years after placement, again, we see a soft tissue recession. Probably again, because the buccal bone was not big enough. As Isman mentioned before, in 2003, we did not pay much attention of the importance of the thickness of buccal bone. Now, if you have a soft tissue recession, as you can see here, you have to tell the patient to do something because you don't want to see the rough surface of the implant out in your cavity. And I proposed the soft tissue graft, but the patient said no. He came back 4 years afterwards, and you see the severe peri-implantitis. And I'm sure that if he accepted the treatment in 2008, the situation would be not so bad. But even in a case like this, even in a case where apparently there are no walls, you can do it. BIOS collagen is fantastic. You graft, but you protect the graft with a connective tissue graft. You adapt the flap, you suture, and you can then, if you're lucky, get good results, and results are stable for many years to come. And last but not least, the regeneration approach is particularly indicated in the aesthetic zone. Once again, look at the situation 5 years post-op. I was happy with the case. I showed the cases many times because I was proud of it. And if you look, 2001 was the placement. For 14 years it was okay. For 15 years it was okay. Then all of a sudden, 16 years afterwards, we got a complication. So no matter what you do, no matter how hard you try, particularly if you have a periodontally compromised patient, peri-implantitis can show up. What to do? Well, there are many choices. You may read that laser works, you may use powders, you may use glycerin, you may use many things. But look at the situation clinically. It's a lateral incisor. If we're going to have a recession, the patient is not going to be happy. So we have to do something, knowing that at the end, you have to be free from inflammation, but also pleasant from the aesthetic point of view. So we have to use a technique which is gentle, small instruments, do not make vertical incision, clean the surface of the implant gently but carefully, remove the granulation tissue, making sure you don't remove healthy tissue, and then again, you graft the area. Do not, after you use a brush, I find these brushes very useful because they clean the surface of the implant, but they don't destroy the surface characteristics. And then you see that if we don't graft the area, if we don't regenerate this, it may heal, but for sure we're going to have a recession. And I don't think there's anyone who will run a randomized controlled clinical trial on a situation like this. So this is the BIOS collagen. We may place a melogenin if we have lost periodontal attachment on the adjacent teeth. We suture and we follow up. And if we are lucky, patient is good and brushes properly, can be happy, and results, if are stable, can be for many years to come. So be prepared because the future will have many of these complications, even if you do things properly. And with this, I thank you for your kind attention.
Great presentation. There are millions of questions. And I chose a couple of them. So talk a little bit about the phase 1 therapy. So you diagnose your patient, or you get a patient like this. Let's say there's an implant and there is bleeding, pus, and all kinds of all sorts of things. How do you prepare the patient for surgery?
Okay, all the cases I showed are basically patients who were under maintenance. So they presented a single problem. So you have to differentiate between a patient who has many problems, including a peri-implantitis, or a patient who is basically under control and has a deep defect. It's like imperio, you see those.
There is a defect, patient is clean, but there is a peri-implantitis defect.
So these are the patient. Now, the problem we have is in perio, we can prepare carefully. We can scale, plan, we can do a lot before surgery. Around peri-implantitis defect, this is very much difficult. I mean, they have to be clean. They have to have a low plaque level, but preparation sometimes is difficult because you cannot scale or plane it that much. So
do you ever use any curettes? Your hygienist use any curettes? What material is she going to use? Or
yeah, I try not to be too aggressive. What sometimes I do is give antibiotics 2-3 days before surgery, so we reduce the bacteria. They use chlorhexidine in the days before. They may use local antibiotics, but you cannot instrument too much around an implant with peri-implantitis because otherwise you're going to have a recession. And you don't want to have a recession because if you do that, then you cannot have enough tissue for regeneration. And we cannot pull up the flap as you do for vertical augmentation. So somehow you're forced to start your surgery under conditions which are not ideal or as ideal as around teeth. But implants are much more difficult to treat than teeth.
And your hygienist ever using a curette around an implant?
Yeah, yes, titanium correct, but I always make sure, be gentle. I always repeat, be gentle. Because by the way, it's interesting, but you see lots of calculus around the tooth, but you never see lots of calculus around implants. We need a scientific explanation for that, but that's the reality.
I think it's also important, what is the macro design of an implant?
Yes.
In terms of how to clean off that implant.
Right.
So which macro design do you prefer?
Probably the one that you saw. Yeah, the tissue level implant, that's what I use. I've been using other implants, but I have tried to apply the same protocol with other implants and I was not able to get this type of success. So typically, generally speaking, when you have those implants very aggressive, very much important for primary stability, for immediate load, well, be careful, because if you do use them for periodontal compromised patient and then you have a complication, you're in trouble. Now, I've seen that you also use implants with a smooth portion in the most coronal part. And I think that's the general tendency. Can be right. Supracrestal at the crestal level, but it shouldn't be too rough.
In terms of the decontamination of the surface, you're using a method, right? You're using how do you select that? And do you see any upcoming method that would be maybe faster and maybe more effective? And number two, do you think you clean all the bacteria off, like to zero or close to?
Well, to answer to question number two, which is very intriguing, I say I don't know. I do my best, I even don't know if actually you need bacteria zero, because maybe it's sufficient that your cells can get rid of the bacteria. So you have to clean carefully, but I don't destroy the surface. We've heard so many years that the surface of the implant is so important, and all of a sudden we see those people using burrs, destroying all the surface. So the surface is important or is not important? If it's important, to me, is important before peri-implantitis and after peri-implantitis, because I wanted to restore the situation. Well, why did I choose the protocol? I really don't remember. It was many years ago, and I don't change it because, when you do the research, you want to keep things in the same way. There are many studies that compare the contamination systems, and basically no one is able to show a preference or a benefit. There are many sophisticated type of benefit of a procedure, laser, powders, all that stuff. But so far,
You
nothing
heard about
is
this
sent.
method in Germany now. It's upcoming with the galvanic method.
Yeah,
Have
I
you ever?
heard, but I have no ideas. The other thing is that nowadays, after COVID, we have to be careful not to spray too much, not to do aerosol. So no matter what you do, you have to be careful not to use something which is effective. Maybe I'm thinking referring to glycine, but of course you cannot use nowadays. But I'm
Yeah,
sure there are two things. One is to concentrate our research around decontamination, and one is to concentrate our research on reconstruction, regeneration. And in the between, the ideal shape and size and surface of the implant is also important. And so there's lots of things we have to study. But I know the material will not be, I know there will be lots of material in the future.
and in terms of the implantoplasty, right? That was the first way to do that. That you basically use a burr. I see some people still using a burr in combination with regeneration, which is to me it's very difficult to imagine that I would use a burr, have all the powder, and then apply a graft material. So, have you ever done that, or have you
No.
ever?
No,
do that?
there are things for two reasons. One is the one I mentioned. I don't like to destroy the surface of the implant. The second is that I have seen treatment here and there, many lectures, and I have never really seen something beautiful. You go a place, you see, if I see your regeneration, I say, okay, beautiful, I want to try. But I've never seen somebody really showing implantoplasty with beautiful results. Maybe they are okay, sometimes are decent. Sometimes it's a way to keep the implant for extra years. But I want to see a high magnification, the restoration of the initial beauty. That's my aim. Do I always get that? No, but that's what I want to work for. In the future, I want to have 90%, 95% of regeneration. How far I'm from there? Well, a lot, but as you know, it's not the first regeneration you did, that it's like the one you do now. But and that's also good for young generation. I know there are many young dentists who are watching us. Well, it's important, first of all, as you mentioned, that they know that they can place the implant, but they have to have bone on both sides. Some people say, you can place a narrow implant. Sure, but it's not the same. You need bone if you think long term, and that's good. Second, if you lose it, you have to restore it. The more you restore it, the better it is for the patient.
Okay, so in terms of the open and close healing, there were some questions, and it also do you ever close the flap over an implant?
No, I don't. There's a nice paper published by Monhier and my son recently. They showed good results. What's the drawbacks? You have to remove the crown, remove the abutment, submerge, which means incision of the periosteum, open up the flap, do the abutment connection, provisional restoration, definitive restoration, very often a connective tissue graft, because if you stretch in mucosa, then you will not have enough seal. How much is going to cost to the patient? I think it's good to study. I think it's good to prove the concept. I think it's easier, of course, because if you submerge everything, maybe there are cases where you can do that if you can, for example, you have peri-implantitis before final restoration. But in an aesthetic zone, for example, like the one I showed you before, would you do it? So I try always to learn more in a non-submerged approach.
The next small question is that, because what the result is that you basically almost never remove maybe the crown, but you don't close basically over the implant. You don't open a flap to reevaluate how much bone you gain. So basically it's like an indirect result: bleeding on probing depth, and radiological assessment.
Correct.
So, but to estimate in this average, severe but average good configuration, good bony trough around the bony walls around the implant, how much percentage you think you're regenerating in a vertical deficiency like that?
In
And that's
terms
the
of
last
in terms of millimeters?
Let's say in percentage of a defect.
Well, I would say more than 70, more than 80, because if you look at the X-ray, I mean, and I showed you, of course, good cases, but even in the average cases, you know, you get good results. And if you don't get good results, you get glidium probing, you get abscess, and sooner or later you remove the implant. And of course, you have to keep in mind that when you propose that, it's not 100% procedure. But now we have more experience, so you now see the 10-year data, but I expect that the next 10-year data are going to be better.
Thank you very much, Mario.
Thank you very much. It was a pleasure. Hope we can share the stage again soon, sometime, somewhere.
Thank you. Thank you.